The broadcast is now starting. All attendees are in listen-only mode.
Greetings, everyone. We appreciate your attendance to this edition of our webinar series, EMS 360, powered by NSEMSTO. We have been doing a number of these sessions in the past couple months and really try to keep up to date in the most contemporary manner possible. So just a few housekeeping slides for you. This is my contact information. I'm Kathy Robinson with NSEMSTO. I think I know most of the state officials that are on the call. There is my contact information. If we do not get your question to your question at the end of the session, please feel free to email me, and I'll make sure that Dr. Fallett has a chance to review them and that we can get back to you on them. As you may or may not know, NSEMSTO is an acronym for the National Association of State EMS Officials. We consider NSEMSTO the lead national organization for EMS, and that work in their states and community. Our members works in states and communities to assist EMS provide the best care available. So as I mentioned, this session is being recorded. The handouts, such as the copy of the slides, because this question comes up on each and every one of our webinars, are available to the live participants. And we do that not to be punitive in that regard, but so that they can be interpreted within the context that they were referenced by our presenters. So at some time during the webinar, I will post them in the menu where it says handouts. The recording will be posted following processing, and it will be on our YouTube channel as soon as possible, probably by Friday. And you can get to that by clicking on the YouTube icon from our homepage. So you see this little menu option on your screen right now. That is the way that you'll be able to send us questions. I will be monitoring those throughout the webinar. And part of the reason that we save them to the end is there's generally several recurrent themes, and we can sort of put those together. Except for Dr. Fallett, all lines are automatically muted. You can submit the questions, and as I said, we will try to get to them by the end. If we don't get to your question, please email me, and we'll do our best to respond to that. We will be monitoring the control panel, and sometimes we can open your line so that you can ask any questions directly. This is a webinar that is being presented for informational purposes only. Those of you that are state trauma managers may recall that a few years ago we actually did a trauma systems monograph that looked at many different elements across state systems and did not focus on pediatrics, but Dr. Fallett has been kind enough to share the results that she has obtained. What we find in the various surveys that we do with state officials, that you might ask one person a question, they will answer it one way, and another person on the same staff might answer it a slightly different way. So just keep in mind that this is a snapshot in time, and that I think we're all just doing the best we can to try to work together. We appreciate everybody's thoughtful participation. Please be considerate that some of the materials might be proprietary in nature, and we're asking that no element of any presentation be copied, used, attributed, or published without the consent of the speaker. And so I think that that's really most of the information that we have to share with that. And without further ado, I'd like to introduce Dr. Mary Fallett. She is a professor in pediatrics at the University of Louisville, and she has been a great partner with NSEMSO over the years in working with pediatric patients and policies, procedures, and those sorts of things. She's a current member of the National EMS Advisory Council, and without further ado, I'm going to turn the microphone over to Dr. Fallett and thank her again for helping us understand the current status of pediatric trauma systems across the country. Dr. Fallett, thank you again for agreeing to talk to us today. Your slides are visible, and we are seeing, I think you might be muted, but
Can you hear me?
yes, we can. Thank you very much.
Well, thank you for that kind introduction, and thank you all for attending. This is a snapshot of a project that's taken about 4 years. Your icon is up there because many of the officials of NSEMSO were partners in this project. So by way of background, I'm first going to just tell you a little bit about why I decided to do this. I am funded by HRSA as Program Director for Kentucky EMS for Children, which is my only potential conflict. And by way of objectives, I'm going to talk about deficiencies in pediatric trauma system development in our emergency care system. I will talk a little bit about pediatric readiness and how this might fit into development of trauma center readiness for children. And I'm going to discuss several ways that non-pediatric trauma centers can begin to approach gaps in trauma care for children. There are several contributors to this program, and the primary ones are listed on this slide. Many are residents in training, medical students, and then there's a couple of other individuals. Fred Rogers is what I consider a rural trauma center, director. He has been very influential in Pennsylvania in development of that system. And then Fred Rivara is a name that's probably known to many of you from Harborview as someone who's very interested in trauma system development. Many years ago, there was a Skamania conference on trauma system development. This was organized by Richard Mullins, a trauma surgeon in Oregon at the time. He was also in Louisville for a while and was one of my professors when I was in surgical training. Frida Hulka, who is now a trauma surgeon and does some pediatric surgery in Reno, Nevada, was doing a research year with her. And this publication is actually the first that discusses a pediatric trauma system and how that might influence care in this country. This was ultimately published. The abstract looked at the results that compared Washington State to Oregon. At the time, Washington did not have a trauma system. Oregon did have a trauma system. Both states showed a similar trend toward declining frequency of death for children, but Oregon clearly was leading in this effort where it was statistically significant, and this was the first study that suggested that children would also benefit from a statewide trauma system. I was privileged to be involved in this project by the Institute of Medicine at the time that looked at the future of emergency care in the United States health system. I was on the pediatric subcommittee, and there were several themes that came out of this study, both adult and pediatric. These were overcrowding in emergency departments, fragmentation of care, shortage of on-call specialists. There was a general lack of disaster preparedness in this country, and there were shortcomings in pediatric emergency care, similar, unfortunately, to some things that we've experienced recently during the pandemic. But in particular, the children's report showed a true variation in preparedness for pediatric experiences, if you will. an uneven presence of people who knew how to take care of kids. Very few emergency departments had all the supplies deemed essential for managing pediatric emergencies. There was a lack of care coordination, great geographic disparities in access, and many providers were felt to undertreat children with failures to recognize cases of child abuse. So some years later, Richard Childress, who some of you may recognize as a NASCAR driver, decided to endow a pediatric trauma center of sorts, research institute at Wake Forest in North Carolina. He started with a $10 million endowment, and 2 summits resulted from that endowment, as well as several grants. At the first summit, a group of pediatric specialists, including not only trauma surgeons, but nurses and neurosurgeons and orthopedic surgeons and other specialties that have a vested interest in trauma care, gathered together and looked at the gaps in pediatric trauma care in this country. That publication in 2014 outlined these gaps, but led to a second summit with the end result of 3 sort of visions of what needed to be done to operationalize a system of care in this country. One of those was to actually look at the pediatric trauma system of care in this country, which really hadn't been done at that point. And so I decided to apply for one of these grants, which was awarded in 2016. And what you're hearing today is some of the results of this study. My specific aim was to develop a contemporary national report on the status of pediatric trauma system planning and development, to assist with future state, regional, and national planning for pediatric trauma care, and also to enhance future research. So you'll recognize your report at the bottom here. My starting point was 2 documents. The first was a General Accountability Office report that had been released in 2017 on pediatric trauma centers that did not really discuss pediatric trauma systems. And your report, which looked at the status of state trauma systems, but didn't really emphasize care for children. So these were my 2 starting points. On the left, you'll see the old report that was what you updated. That came from the National Conference of State Legislatures in 2006, and the Committee on Trauma, which was at the time where the state trauma directors were based, was the origin of some of that report. And then, as you know, the trauma directors relocated to NASEMSO, which was part of the reason that the subsequent report was done through your organization. I also wanted to remind those of you on the call that at one point the federal government actually funded trauma system development in this country. In fact, it was done through EMS for Children as a supplement in 2001 and 2002. And since I was the EMSC program director at that time, this came through our office. And then ultimately we applied for a 4-year grant, but unfortunately, although awarded, those grants were, the funding was pulled after a year. And so many states had funding that they lost when the federal government withdrew the support. So the GAO report was somewhat illuminating about trauma centers. It did find that 60% of the 73 million children at the time, which looked at 2011 through 15, lived within 30 miles of a pediatric trauma center, which sounds really good. However, in 8 states, none of the children lived within 30 miles of a pediatric trauma center, and in 15 additional states, less than a quarter lived within 30 miles. So this was certainly a gap. And even in states that designate trauma centers, nearly half of injured children are treated at non-trauma centers. The map at the bottom left is from that report. The white states are states where most children are not in proximity to a trauma center, and the dark green states are where most children have access to a pediatric trauma center. And at about a similar time in the right upper corner is an ATS map from the Trauma Information Exchange Program that shows where level 1 and 2 pediatric trauma centers are located. So you can see a lot of overlap. One thing that you'll also see is the bottom report is less than 18 years, the top report is 0 to 14 years, and the age of a child is inconsistent between these reports as well as other reports. And quite honestly, I don't know that we will ever have consensus on what the age of a child is. These are 3 maps from the GAO report that look at what happens when you increase the trauma centers to level 3s and 4s. And so on the left is the percentage of children within range of a pediatric trauma center. In the upper right is a level 1 or 2 adult or pediatric trauma center, so a high level trauma center. And at the bottom is any trauma center, including level 3s and 4s. So obviously, the more you include any trauma center, the less likely it is that a child won't be in proximity to some access to trauma care. You're all, I'm sure, familiar with this slide. Also, looking at the chances of an individual EMS provider treating a child, it's fairly low, which is certainly exemplified more when you live in a rural or underserved area, where the chances of an individual EMS provider taking care of a really, really hurt or really, really sick child decreases, as does their experience with this. I also wanted to just acquaint you a little bit with the workforce for people like me. So I'm a pediatric surgeon, and in the upper left is where we work and live. White, again, is low density of pediatric surgery subspecialists and specialists, and dark green is where there are a lot of us. So metropolitan areas of larger cities, there are a lot of us. In the lower panel, you'll see where pediatric anesthesia practices. These are hospital referral regions. And one of the conclusions of this paper was that 10% of our children live in an HRR without a pediatric anesthesiologist, and nearly a quarter without a pediatric surgeon. And then to remind you, the familiar map in the upper right looks at where pediatric trauma centers are, and you can see how much overlap there is. So where there are no pediatric specialists, there are generally no pediatric trauma centers, and so there's this huge geographic void in this country for pediatric trauma specialized care. So just a little bit about how we conducted the project. The first thing I did was get a really bright and organized college student to take the data from the NASEMSO report and from the GAO report and to put it in a great big spreadsheet by state. And that took a while. But once we had it, we then looked at what was missing. And then I decided that the groups that should see the survey needed to, in many cases, be state officials, because a lot of what happens in a state is based in statute or protocol. I also included the Committee on Trauma state chairs, but quite honestly, the groups who were based in NASEMSO were really the groups that should have had more of a handle on what was going on in their own state. And so we developed a survey monkey, validated that using a psychometrician from the American College of Surgeons. And then we took by state each of these 4 people, and we took the data that we already had from the NASEMSA report and the GAO report and asked you all to make sure it was correct and still current. And then we took the survey monkey and we deployed this to the 4 people in the same email. And in addition, we sent a hard copy of the survey that we wanted you to fill out so that you could do that first, and one person could upload the answers so that we didn't get a lot of duplicate answers. I highlighted EMSC program managers because, quite honestly, this was the group that I think was most helpful, but they were also more of a captive audience because I'm one of the EMSC people. And so I was able to go to meetings and talk about the project, and so I had their interest. And so, as you can imagine, I did discover that there are limitations to any methodology, despite the fact that you are very granular with the instructions. And that is that several people didn't read the instructions, and so they sent the survey back, and there were a fair number of answers that were different depending on who answered the question. So we did resend the surveys to resolve discrepancies. If I knew somebody, I called them up to see if they could help me. And then ultimately we had all of this data that we needed to do something with, and decided to develop a scoring system using a Delphi method to give each state a score. So this is the first slide that looks at my timetable, and it literally took about 2.5 years to develop the survey, send it out, remind people if they didn't fill it out, follow up on states who didn't send anything back, and then to reconcile the data that was different in the states. With respect to the scoring system, there was a 14-member team of representatives from sectors that had a vested interest in pediatric trauma care. I did go to Kathy Robinson and to your groups to help you identify someone from some of your groups to help me. There was an iterative process of voting. There were 5 rounds of surveys, as well as one big in-person webinar, and we ultimately identified 6 domains and ideal metrics within these domains to develop our scoring system. These were the people who participated, so you'll see some familiar names there, and these were the domains, and I'm going to show you the metrics in each one of these. On the right is the weighted average that adds up to about 100. So a perfect score is 100. There are a few states that were nearly there. But I did want to also mention that despite some states having all the building blocks in place, it does take coordination of that system to really make things great for kids. So just because you get a high score doesn't always mean you're doing a great job. So in the disaster domain, and again, these are ideal. The state disaster plan would include children. The state would hold mass casualty drills that include children. The mass casualty drills would include facilities planning for transfer of children to accommodate surge, and a process for identifying children to be moved and verifying facilities as having appropriate resources to provide optimal care for kids. Under legislation and funding, there's state legislation for trauma system development with mandatory pediatric representation on the Trauma Advisory Council, And the legislation specifically calls out children and includes planning, simulation, and modeling. The state has enabling legislation to designate pediatric trauma centers, and there are some state funds for pediatric trauma care. Access to care looked at the field triage guideline and whether the state uses it, whether there's access to rehab beds, burn beds, and then we also decided to use only the maps from GAO that included living within 30 miles of a high-level pediatric or adult trauma center or any trauma center. So we did not use the maps in the data for pediatric trauma centers because we wanted, again, to assure access of care, not necessarily access to specialty care. For injury prevention and recognition, state legislation is in place to review child fatalities due to injury, including child abuse, that all levels of trauma center have education programs for their staff that include recognition of child abuse, and that state agencies, health departments, or the trauma system lead efforts in organized injury prevention for children. For quality improvement, we looked at the trauma registry, whether it was public data, whether it included children, whether it was used for PI, and then similarly, we looked at EMS data. Pediatric readiness, we looked at the pediatric readiness score, but more importantly, we looked at engagement by the state in participating in the survey in 2013. We looked at whether the state officials said, yes, we have transfer guidelines and defined protocols in place at our hospitals to transfer patients to a higher level of care. And the last one is more elusive. I'll talk about it in a little more detail, but it's about ALARA guidelines in using radiation that is as low as reasonably achievable, particularly for children. We brainstormed our score name and we decided to use the last one, Pediatric Trauma System Assessment Score, which is what you'll see a little more of towards the end of the presentation. And then here is the second round of our timetable. So this was our Delphi survey process, which took about 9 to 10 months. And then, as you'll see later, there was still a fair amount of missing data that we felt we might be able to reconcile. And so Amelia Collins and I went to the web and tried to find any type of public data that would enable us to give every state the benefit of information that someone didn't fill in. And we also referenced it if we found some information that we thought we could use. And so that gets us up to about today, which is this report, which I'm giving you because you were a participant in this study. And then there's some deliverables, and we have the first manuscript almost completed. So each state will be getting an abstract. It's 3 pages. There are 88 data points. And we've color coded it because the information comes from different places. So if it's green, it's come from that GAO report. If it's blue, it came from your report, your last one. If it's orange, it means it's our question. And if it's next to one of your questions, the answer is, it means that we updated it. So in many of the reports that you'll see ultimately when you get your PDF of this project, you'll see that in your report there was a fair amount of missing data, and we have been able to update many of the answers from the state so that it's a little more current. And then a highlighted row means we included that particular metric in our scoring system. It will look something like this. I have the North Carolina one up here just because that's where the money came from. But each state will have an abstract that looks like this. It actually is a database that hopefully we can keep and might be able to be updated. So I'm going to give you just a little bit in the way of results. I tried to make it simple, but to give you some of the overarching concepts. So most people will be happy to know that almost every state has legislation now. The District of Columbia does not, and the state of Vermont does not. Children are addressed in the state statute in 40 of these states. They are not addressed in these states. There are trauma advisory councils in almost every state that has a statute, with the exception of Missouri. And there's pediatric representation in 32 of those advisory councils. If there is an advisory council and someone happened to be a pediatric representative, but they do not call that out in the statute, it didn't count. So as far as we were concerned, the statute had to say that someone was representing pediatric interests. And here's the states where children are not represented on the state trauma advisory council. And honestly, this is not to make these states feel bad or the state officials feel bad. It's illustrating a gap that hopefully after this report's released could be fixed. Understanding that to change a statute or any part of it usually requires the legislature in a vote. So it's not a small task, but it is important. This is access to care and destination bypass. And so we did ask about whether the field triage guidelines were used. Point of information, these are currently being updated. It's granted the contract to the Committee on Trauma. I am representing the American Academy of Pediatrics on that task force, and we are about 2/3 of the way into the process. And in fact, you probably will be able to see that draft. The draft was released recently. Is there a state trauma destination bypass protocol in place? And then is there a state pediatric trauma destination protocol in place? And the results on the right are for pediatric destination bypass. So here's the answer to the question, are CDC field triage guidelines used in the state? Yes is red without modification. Blue is yes, but with modification. And orange is no, we use other guidelines, or there's no state mandate. For your report in 2016, there were 24% non-responders. We were able to get a response from every state. On the left is looking at a state trauma destination bypass protocol. So most states have one. And on the right is looking at a pediatric trauma destination bypass protocol. The gold are those that did not respond to the question. I imagine probably they don't have one. Injury prevention and recognition, in particular child abuse. We wanted to know if the trauma centers in general have guidelines for recognition of child abuse, and if there's state legislation for child fatality review. We did ask EMS for Children to help us with this so that we would get it right. And we asked the states if they have shaken baby parent education, and if they said yes, then we presumed we could go to the web and figure out where that legislation was, and we could. And then here's a slide that just depicts that. So the first column is adult trauma center EDs have guidelines for child abuse recognition. Second column is their state legislation for child fatality review, instructive on child abuse. Most states have this. Third column is their mandatory death review of childhood deaths resulting from abuse. Most states have that. And then the last one is, does the state have parent education legislation? And you can see there are even a fair number of states who have that now. Then we looked at PI plans and children's interests. This is something that should be public information. And so on the left is the state PI plan and whether or not children were recognized. And this was in terms of trauma registry data. We asked if the state trauma registry was electronically integrated with pre-hospital data. You had also asked this question 4 years ago. We were able to update it, and there actually are 22 states now that do have trauma registry electronically integrated. And I also checked with Clay Mann to see if this was accurate, and he thought that our list matched his list. Hospital transfers. So this is probably one of the biggest hurdles, challenges facing children who are injured in a rural environment, and that is that the individuals, the medical team that work them up, are scared of them, and they do too much workup. You've all heard of man scans, I'm sure. A lot of these kids get far more radiation than they need, and they get it before anybody calls us. And so one of the hurdles, again, I think, is to help referring hospitals understand that they really don't need to do all this workup. They can call us, tell us what they're seeing. We can help them decide what they need to do before they transfer the child. Hopefully, one thing the pandemic has given us is a resolve to use telemedicine more effectively. And many of the states, not necessarily the entire state, but systems of hospitals now have teleradiology push capabilities so that we don't have to worry about getting the disc. They can actually share their films. I alluded again to ALARA. It is really difficult to know if hospitals use ALARA guidelines. I've spoken with the president of this organization. He said that no studies have been done to look at this. Again, a gap that really could be explored to help people understand that when you do these scans, it's an incredible amount of radiation for a small child, even for an adult, but for a child, it could be associated with a lighter risk of malignancy. So you're all familiar with pediatric readiness, the champions for that, the scoring system. The current survey was just completed, but I expect it'll be several months before results are released. But the original study showed that across the board, there was about an average of about a score of 70. And if you were a low volume hospital, i.e. saw very few pediatric patients in your emergency department on a daily basis, the score was traditionally lower. And this led to a checklist for emergency departments to be able to ascertain their readiness. There are plenty of papers now that have been written about this and about its virtues. There's a whole national effort. But I think the important point here is that if you can take good care of kids, then you can also take care of kids who are hurt. So a few studies have been published that relate pediatric readiness to outcomes. This one by Ames looks at how it relates to mortality in ill children, not injured children. But the higher the pediatric readiness score, the lower the mortality. Then there have been two that looked specifically at trauma verification. The one in front of you from 2015 was actually within a bigger paper, but it called out trauma centers. And if you were not a designated trauma center, typically score was around 68. Level 1 and 2 trauma centers, 87. A pediatric designated trauma center, 95. But a level 3 or 4 trauma center, 65, which is lower than a non-designated trauma center. I've always said that an injured child should be taken to a trauma center, but if you can't prove that the pediatric care would be better at a trauma center than a rural hospital, I'm not sure that the claim is valid. And so my feeling is that we have some work to do in some of these lower level trauma centers to enhance their pediatric capabilities. And then this was a paper published a little more recently in the Journal of Trauma. These were self-identified trauma hospitals. And once again, it found that non-children's hospital EDs have a lower pediatric readiness score, as do the lower level trauma centers. The issue with this particular paper, though, is I was able to look at the data for Kentucky, and many of these self-identified trauma hospitals are not, in fact, trauma hospitals in Kentucky, self-identified or verified. And so I'm not sure of the validity completely of this data. Nevertheless, it does agree with the California data. We decided, along with Kate Remick, that in order to get a yes for engagement with pediatric readiness, it was not going to be based on the score, but on greater than 80% participation of the hospitals, recognizing that to be engaged, you have to participate in the survey. And so we did not penalize the state if their score was 65. We only gave them a no if a very low number of hospitals participated in the survey. And these are the states that did not have significant participation. Transfer agreements of interest to me, since EMS for Children has a performance measure that is about transfer agreements, and we've been preaching this for years. There were 14 state officials who said that their hospitals did not uniformly have transfer agreements, and they're listed here. So this is another gap that I think would be fairly easy to close. And rural trauma team development courses are offered by the American College of Surgeons. 34 states have these. There is a small pediatric chapter, so there is some pediatric trauma principles that are taught in that course. However, many of the American College of Surgeons courses have had a declining amount of pediatric content over the years. And so if we really want to engage state emergency departments in how to take care of children, we either need to recognize that and increase the content, or perhaps even develop our own course with simulation that would help educate our teams in the emergency department. The next thing we did was we looked at some pivot tables based on our scores by regions. Colin Traeger was a medical student at the time. He's now a surgery resident in Austin, Texas. Here are the scores of the different states. So this is the collective map. I guess it probably wouldn't surprise people to know that there are several different regionalization schemes in this country. I did give this presentation last week at the EMS for Children meeting, and Rachel Alter let me know that NSEMSO has a couple of different variations on their regions, and I've not had time to go back to my team to have them do a new pivot table, but your NSEMSO regionalization map is coming up here shortly. This is EMS for Children, and so depending on what state you're in, you're going to likely be in a different region. But what this enables us to do is to look at potential regionalization of even grants or things where a state that is particularly well versed in pediatric trauma system development could help a state that is less well resourced. So you could imagine where you might have some type of demonstration grants that could occur by regions. These are the Committee on Trauma regions. These are the NASEMSO regions, and again, there'll be just a few changes in this particular map. Your regions are quite a bit bigger than some of the others. And then this was the US Census Bureau. And the reason that we did this last one will become obvious here in a minute, because when you develop a scoring system, I think people will say, well, so what? What does that mean? And so you need to go through the process of trying to validate it. So we're doing that in two ways. One is completed and one is ongoing. And the one that's completed was using the CDC Wonder database, which is the wide-ranging online data for epidemiologic research. But this basically looks at the mortality rate of children, or allows you to look at the mortality rate of children under 18 with traumatic injuries by state and place of death, whether in hospital or out of hospital. So we did a unadjusted linear regression of our score with mortality. The mean score was 74.4. And in the years where most of the data was collected, the overall mortality rate in children due to injury was 14.2 per 100,000 children. In-hospital mortality was 7.4 and out of hospital 3.5. And we detected that for each 1 point increase in our score, there was an associated 0.12 per thousand decrease in overall mortality. We're also able to show a significant decrease in in-hospital mortality and a trend toward a decrease in out-of-hospital mortality. And here's some of the raw numbers. Out-of-hospital mortality, I think, is a little more understandable that might not reach significance. Certainly EMS is a big component of that, but as most of you know, if a child arrests out of hospital from trauma, typically they are not going to be resuscitated. And in some of these more rural states in particular, where someone might not be discovered for a while, it sort of makes sense that the out-of-hospital mortality would be fairly, would be the same, regardless of whether or not you get there early. So opportunities. First, I just wanted to show you a map of level 1 and 2 trauma centers. Adult is on the left and pediatric is on the right. And if you compare that to level 3 and 4 trauma centers, you can see how many more 3s and 4s there are in this country, and that they cover much of this area that currently is not well served by trauma centers that are higher level. And on the bottom, you can see there's just a few scattered level 3 pediatric trauma centers, some in Washington State, and then a couple in some of the other places in the country. So I think that is something that we as trauma surgeons should work on, which is to try to get more level 3s and 4s to up the ante on their pediatric capabilities. Ultimately, we will also use HCUP data to see if we can validate our scoring system. We've purchased the database, and we have some statisticians looking at it now. We do have this real-time database that would be capable of updates if we can find some funding to house it. We have the potential to do resource allocation using regional development. And then, as you know, the Committee on Trauma does system level reviews, and there really aren't pediatric trauma metrics, so perhaps this study could be used to develop some of those. With respect to level 3s and 4 trauma centers, I think there are some intuitive ways that a trauma center could prepare for becoming more pediatric ready, which is the first step, which is to go to the website, do the survey, compare their emergency department to the state average, do a gap analysis, look through the toolbox that's available, appoint a nurse, an MD, pediatric emergency care coordinators who would be in charge of QI and training, and begin to address the gaps and describe how they are doing this. And ultimately, I think this may become a standard for verification. In addition, as you know, EMS services are doing this all over the country, where they're identifying pediatric emergency care coordinators. We're doing it in Kentucky. We have a lot of buy-in, and I think it really will make a difference in terms of care. And with respect to messaging, I think it's not just about pediatric readiness, it's about team building. So whether it's EMS or doctors or nurses in rural communities, we need to help them build some confidence. They see a kid and there's stress, there's anxiety, and having to provide care to a kid who's really sick or really injured. And so it needs to be a team effort. We can't do it without your help. You can't do it without our help. And it needs to be a concerted effort to raise all boats. Many of you have probably heard that there was just a multi-million-dollar grant awarded through HHS to support regional pediatric pandemic network development. There will be 5 hospital hubs, including one that is related to trauma care. And in goal 2, one of the things that they stress is to improve pediatric readiness across health systems influenced by children's hospitals. I just wanted to emphasize that infrastructure building is part of this process, but that it, again, has to be a team effort. It has to reach every level we talked about in order to make it successful. And the PI of this grant is Charles Macias, who's at Rainbow Babies. Co-PI is Chris Newton, who is a pediatric surgeon colleague of mine, and he is in San Francisco. The hospital where I work, Norton Children's, will be the trauma and burn hub. And then the EIIC EMSC trauma domain is has also formed an alliance with the Committee on Trauma that's led by Aaron Jensen and Michael Dingledine, and then Lisa Gray is staff support through EMSC. So some good people who are leading this effort. So my deliverables for this project ultimately will be a few hard copies of a book. There'll be a downloadable PDF. Each state will have its own abstract. And there is updated information from the last NASEMSO report. So I think it's reasonably timely data. The report will be about 250 pages, and it's over half done. I was planning to come to your meeting in Reno in November, but I'm not sure if there's going to be a meeting. And so I will offer that if you have comments, Kathy does have a PDF copy of this presentation that she will share with you all. I'm really happy to hear feedback, things that you'd like to see in more granular fashion. We also have a manuscript that's about done that needs to be submitted, and that needs to be done before we release this report. So that we're in process. So with that, I'll wrap it up, and hopefully we have a few minutes for questions. You know, it's about 2:55, but I do have time to stay later if there are questions that I can answer, or I'm happy for Kathy to send out my email, and you're welcome to email me with your questions. So thank you for your attention.
Well, Dr. Fallon, I wish that there was a way that we could share a round of applause, because that was a fantastic presentation, very informative to all of us that are interested in the care of pediatric patients. I don't have a whole lot of questions, and there are a few that came in that were actually the same, and the question was really around how each state would receive their the copy of their abstract. And you and I haven't really discussed that at all yet, but certainly NASEMSA will be helping Dr. Fallot coordinate that information. I suspect that we'll make sure that the state director has it and first, and I recognize that sometimes it doesn't filter down to the individuals that are most responsible for implementation of recommendations and those sorts of things. So we will do our very best as a team to make sure that the state abstracts get to the right person, and that's my commitment to you, Mary, as far as coordinating with the distribution of that information.
Yeah, and the abstracts will be in the PDF. And so this is, you know, as far as I'm concerned, most of the data was from those 2 reports, which are freely available on the web. And much of the data that was missing that we filled in was from the web. And so it's public data. And the PDF will be similar to yours, where if somebody knows how to get it, they can download it. The hard copies, and you know, I think that people probably wonder, well, why are you even making hard copies? It's easier to compare. I think states, not that is something that. So this is not a report card. This is a way for a state, just like with the EMSC program, where you recognize your gaps and you try to move forward, and you update things as you go. But if you're in a certain region and you have a state that's your neighbor and you look and they're doing it in a way that seems to make sense to you and you want advice, it enables you to then go to that person and to try to get some information or some help. And so we felt that some hard copies that would enable you to go from page to page instead of trying to switch screens to look at something online made sense. And so the books, the hard copies, it was our goal to distribute those to the trauma managers, the state executive directors, and the EMSC program managers. And then we'll also give a copy to the COT state chairs. We had money budgeted for this. The book is a little bit longer than we imagined it was going to be. So I do have to come up with a little bit more in the way of funding for that initiative. But my daughter is the graphic designer. She helped with these slides that you just looked at. And so, you know, I have a captive audience in my own backyard. And so she is about halfway or 60% done with formatting all the state abstracts, and should be done with that in the next couple of weeks. And then we just have to get the rest of the data in a format that is understandable. But you've seen some of the way that it will be portrayed here, and we're taking information from the NASEMSA report so you can see how they collected the data and interpreted it, and then we will update it in our report.
Well, I think I can speak for the state officials that are on the call that we appreciate the efforts in not presenting this in a report card format. As you know, one way or another, these sorts of things tend to land on the desk of legislators that may or may not understand the output. So thank you very much for that. I'm getting like tons of very informative and well done kinds of comments. Thanking you for this great presentation. We will be in touch. I don't see any other questions in my screen. I'm going to give you a few seconds left if you have anything specifically you would like Dr. Fallot to address. Thank you for your years of effort and for sharing what you learned so freely, Dr. Fallot. That was intended for you, so I'm happy to pass that along. Again, this is really a collaborative effort and really one that is, I think, a labor of love for everybody that's been involved. And I think I'm pretty sure I can speak for the audience too, that you're very lucky to have a graphic designer at your at your behest. So congratulations for that. Last, yep, just basically gratitude. Dr. Fallot, thank you again for a very informative session. Folks that have any questions that they think of after the fact, they can email me, robinson@nasemso.org. Again, this is really intended to be an open discussion and a way for us all to work to improve the status of care of children in the country, not just in trauma, but in many different regards. Our focus today is on trauma, and we look forward to strengthening that to the best of our ability. Dr. Fallot, Dr. Remick has been on the presentation. She is sending her regards as well, and I think that we all again join her in our applause for the session. So, without further ado, I'll give you the closing comments, and then we will adjourn for the afternoon. Thank you again, Mary. It's back to you.
So just thank you all for tuning in. And again, I am happy to do this again towards the end of the year. If you don't meet in person, if you do meet in person, my plan is to come. Hopefully, I know Tuesday is a lot of the groups getting together and having joint meetings. So I would try to be there on the Tuesday so that we could look at this in more granular fashion if you wanted to do that. And otherwise, if we need another session just to talk a little bit more about challenges and how to approach them, I'm happy to do that. So thank you all. Have a good afternoon.
Thanks to all the attendees and to Dr. Fallot. Have a great day. Bye-bye.